All right, everybody, welcome to Piriformis Syndrome, aka the biggest pain in the ass. Literally, dad jokes. Let's get into it. If you guys are looking for good dad jokes, go download Andrew Tran's dad joke. I think you can buy a book too. It's basically physical therapy dad jokes. It's by Andrew Tran if you're looking for it, but it's a good time. But anyways, let's get into our Piriformis Syndrome. So why does Piriformis Syndrome happen? A lot of times it's due to just compression of the piriformis on our sciatic nerve, which, newsflash, that's all the anatomy really associated with this that we have to worry about. The piriformis muscle, which is one of our deep external rotators of our hip, and then our sciatic nerve, which supplies most of the innervation to our hamstring musculature, and then it breaks off into our common peroneal nerve and our tibial nerve to basically innervate the rest of the leg. So pretty much our sciatic nerve is innervating about like 70% of our entire lower extremity. So if we got a problem with our sciatic nerve, we got issues. So that's why this ends up being a big problem for a lot of people, because it causes them a significant amount of pain. So how does this end up happening? So let's talk about one of the number one reasons, which has to do with the anatomy. So in most people, so if you're listening to this on the podcast, you can't see this image, but just kind of follow along with what I'm saying. If you're on YouTube or in the course, you can see this image here, letter A. Most individuals, their sciatic nerve goes underneath the piriformis muscle. So it just pops out from underneath. As it goes through, it goes underneath it, and it pops out. It's like, hello, and it goes down the leg. And that's kind of what it does. So therefore, most of the people who end up getting sciatica because of this, like, anatomical variation, and there's so many anatomical variations, as we kind of talk about. Most common one you hear about is like, not everyone has a palmaris longus. Not everybody has a psoas minor either, and you won't be able to know that unless you cut yourself open, which don't do that because it's really deep in there. But lots of anatomical abnormalities, this is one of the pathologies that it ends up being a problem with. So in most people, your sciatic nerve goes underneath your piriformis. In a very, very small portion of the population, your sciatic nerve actually goes over your piriformis, which then sitting on your piriformis might cause it to be painful and cause problems and compression of the nerve, which then therefore causes neurological symptoms down the leg. So that's one of the reasons why this could happen. A lot of times the piriformis ends up, cushioning a little bit of that sciatic nerve, that it ends up not causing too many problems with our normal anatomical variation of going underneath. However, it's when it goes over top that can cause some problems. And then this anatomical variation, which is about 14% of the population, this is going to be the one that causes the most problems. When the sciatic nerve actually bisects in some sort of way, so goes through the piriformis muscle itself. So if you're on YouTube or like the course, you can see this right here, how it goes straight through these muscles here. So again, if it's going straight through the piriformis muscle, we can imagine every time you contract your piriformis, externally rotate or like sit on it or something, or the muscle starting to shorten or tighten up, anytime that's happening, it's putting pressure on the nerve. Anytime we have pressure on the nerve, so if you're sitting here at a desk studying, if you're leaning on you're leaning on your like head or whatever, and you're starting to doze off, first of all, hello, wake up. Second of all, you might start feeling your funny bone, your ulnar nerve going numb if you put increased pressure on it. So again, same sort of thing with Piriformis syndrome, putting more pressure on it, contracting the muscle could cause it to compress the nerve. And then you get those nerve symptoms of numbness, tingling, or even shooting and burning pain. Any of those symptoms of shooting, burning pain, or numbness or tingling, if you hear any of those keywords, always think that nerve is involved. So this is what's going on. The piriformis muscle itself and the anatomy of it could be causing the actual piriformis syndrome. So anatomy, that could be one reason why you end up getting our piriformis syndrome. Our second reason why, besides our anatomical abnormality, which you cannot change, it's just like, well, it is what it is. You got to deal with it that way. Things that you can change are pretty much these other ones, besides like you can't choose to get a car accident or get hip surgery. It's kind of ended up being your option. But prolonged sitting, this is the number one cause of piriformis syndrome. If you are sitting on your butt, you are sitting very close to your ischial tuberosities. You're also sitting on your sacrum pretty much too. And then guess what connects from the back of your femur to your sacrum? Your piriformis. Yay. So therefore, that prolonged sitting, especially if you have like an increased lumbar, not like an increased lumbar lordosis, or even like just how you want to be sitting in a certain chair at different pressure points, that's going to cause increased pain on that sciatic nerve because you're literally like squishing the piriformis. And so therefore it's going to increase the symptoms. Another cause of piriformis syndrome can be obesity. So the more that you weigh, the more stress there is on all of your tissues, which also includes your piriformis muscle. So remember, this is a big thing. The boards, there's going to be a lot of conditions that obesity is going to make worse. So increased weight just causes increased mechanical stress on the body. And so therefore it can cause things to break down. Basically, what I want you guys to understand is that's a boards thing. Just know that that's something you have to keep in the back of your mind. If the patient, especially for lower extremity osteoarthritis and stuff like that, obesity is a big thing that can cause that. Now, when you're looking at your patients in real life, don't just say, oh, I see a fat person, that's why they have problems and that's the issue. Might not always be the case, friends. Will weight have to do with some people? Yes, it will. However, we have to look at the entire person, make sure we're treating them as a whole person and not just seeing how they look on the outside. Okay. So just make sure you keep that in mind for your clinical treatment. Just always want to make sure we're being, conscious of that. But when it comes to board stuff, definitely one of those causes, keywords that you should be looking for. Trauma or surgery. So again, yeah, if you get stabbed in the butt, might have Piriformis syndrome, get in a car accident, break your pelvis, break your sacrum, break part of your femur or something like that. Yeah, that can happen. That can happen. Yay. And then another sort of trauma where they're actually going to slice the musculature. They actually do cut through part of the piriformis muscle. They detach it and then reattach it somewhere else. Some surgeons slice through it, whatever the hell the surgeon wants to do. I can't tell them what to do. They went to a lot more school than me, but for a posterior approach, total hip replacement, yeah, you're cutting through that muscle, you're cutting around that muscle, you're reattaching, reorganizing where the piriformis goes. Of course, that can cause problems because it's not going to heal exactly the way that it was when it started. Altered gait mechanics. So again, somebody who's like limping constantly, somebody who, has that Trendelenburg gait sort of thing going on, or other problems of antalgia or whatnot. If you're altering your gait mechanics, it could alter how your piriformis contracts, which then could put increased stress on the sciatic nerve, especially if you have that anatomical abnormality. And then putting yourself in an anterior pelvic tilt. In an anterior pelvic tilt, what happens is that stretches out the gluteal musculature. And so it could cause the piriformis muscle to get stretched and weak, and then it doesn't contract well, and then that causes other problems. Could you also have it with a posterior pelvic tilt? You could also, but the book has said that anterior pelvic tilt has to do with this. So we're going to stick with that just to make sure we cover our bases, because Score Builders put it in there for a reason. And yes, I get a lot of my material from the Score Builders book and other books. I compile all the information that I've studied over the past couple of years. It's all in one concise location at this point. That was in there. Don't want to leave any stone unturned. So what does it look like? So again, as we talked about, the patient's going to have pain right there at the sciatic nerve where it pops out of the sacral nerve plexus and creates the big sciatic nerve and bundles all together. This is a big ass nerve, guys. This is the longest and longest nerve in your body too. So you might have pain in the butt, literally like in your buttocks, your hip or groin area, so it could refer towards the front, but a lot of times it'll radiate down the back of the leg. So not the front of the leg, the back of the leg. If it's the front of the leg, you're thinking something coming from the back. Now again, as PTAs, we're not diagnosing, we just have to know what these symptoms look like. This person with piriformis syndrome, their pain's going to be localized to their hip area. They're not really going to have any back symptoms, and it's not going to change with back position. Okay, not going to change with back position. So I'm going to say that again. Piriformis syndrome will not change with the lumbar spine position. Now, if it was a true radiculopathy, like a herniated disc or like a stenosis or spondylolisthesis, whatever the hell it else is, now that could cause back pain. But this is located just in the hip and then can go down the leg. So it's not going to go up, it's going to go down. Nerves, pain shoots down. And as I said before, because of sitting position, you're going to have increased pain on that piriformis musculature. And so because of that increased pain in that sitting position, that's where you're going to end up having more pressure and more nerve symptoms. So again, pain could also be worse if you're pulling on the piriformis muscle, so it gets stretched out too much, can also be a problem. You got to find that sweet spot of like elongation without like squishing it kind of thing. Weakness in hip external rotation and abduction. So basically the action of the piriformis muscles performs external rotation of the hip. And then when it's bent at like 90 degrees, it can perform abduction of the hip. So again, those are the things that are going on with the piriformis muscle. And again, as I said before, lumbar position, does not impact pain. This is not a spinal pathology. This is a peripheral problem in the butt, literally. Anyways, how are we treating it? Again, this piriformis stretch right here is like the number one thing. People think piriformis syndrome, they're like, all right, stretch. Yeah, it does help. We have to stretch and strengthen, though. We can't just stretch the crap out of the muscle. We gotta also strengthen it as well. So strengthening of the abdominals and lower extremities in general. So doing those hip strengthening exercises definitely help. Stretching is going to make a huge difference though, guys. So stretching is going to make a huge difference. I like this stretch. So if you're on the podcast, you can't see this picture, but basically it's you're laying supine and you're taking one knee and you're pulling it across your chest. That is how I like to do a piriformis stretch. I don't like the one where you like thread the needle and pull through, or like take a towel and pull it through. That is too much effort. Just grab my knee and pull it over towards the opposite side. Feel that stretch in the outside of your hip. This is an easier stretch for some patients and more manageable. Some people can't handle holding all the way down. You can also still use a towel to help out. Just be careful. Don't pull on the ankle, guys. Always pull on the tibia. If you're pulling on the ankle, you're just stretching them into inversion. That doesn't help because that's how you sprain your ankle. And so soft tissue mobilization of the piriformis muscle tends to work. My favorite thing, I grab a lacrosse ball and I just take that sucker, put it on where the piriformis is, and I press. And sometimes that releases the muscle. That's my favorite. It works better. It's better than like if you're massaging someone's butt, it can get a little funky. So lacrosse ball, especially if you're a guy massaging a female, that's the way to go. Lacrosse balls are your friend. I literally keep one in my bag when I go to clinics. I love my lacrosse ball. Makes it so much easier. But soft tissue mobilization of the piriformis is basically going to be our answer here. And then heat and stim can help. So help it using those properties of heat, conduction, of like a moist hot pack to help loosen up the piriformis musculature and elongate those muscle fibers. And then stim can help just calm down the area and decrease the amount of sensation of pain in the area. And again, hip mobilizations tend to help as well. So if you notice the patient had like, hypomobility of their hip in whatever direction that the PT identified, like joint mobilizations might be helpful to help either one, alleviate some of the pain symptoms. So grade 1 and 2 can alleviate pain, or 3 or 4 can help increase range of motion. Now we're not doing grade 5s on the hip. As PTAs anywhere, I don't think you can do grade 5s except like on military bases. There's like no rules, but we're not worrying about that. We're worried about 1 through 4 most of the time. Just know 5 is just the snap, decrease pain, happy sensation, cracked your back, yay. We don't do that as PTAs. We're doing our own thing. So anyways, keywords here. So if you see sciatica or anything like that, just think piriformis syndrome could be happening. Remember, sciatica either happens because the sciatic nerve is trapped in the piriformis musculature, or it is coming from the back. So like a radiculopathy sort of thing. So those radicular symptoms are going to be present. Now you just got to see, is it in the back or is it in the hip? Again, we're not going to be the person diagnosing this, but just understanding that piriformis syndrome is at the hip and lower, not up into the back. So numbness, tingling, burning, all of those are going to be signs of neurological involvement. Sedentary lifestyle or job, which 1 increases chances of obesity, and 2 increases the chance that they're sitting all the time, which we know that sitting is going to be the number 1 reason why patient ends up getting piriformis syndrome, just from that pressure on their muscles. Tight hip musculature, so decreased flexibility of the piriformis muscle, literal pain in the butt, so pain in the buttocks area. And then the pain should alleviate as they go into a standing position. So remember the pain in their hip, it's not so much in their back. Remember, there's the big differences here because there are specs. There is like a sciatica and then a herniated disc present very similarly. Just know that the herniated disc is due to back and lumbar problems. This is due to entrapment at the piriformis. So let's talk about our sample question. A patient is being treated for piriformis syndrome. Which of the following workplace adjustments would have the greatest impact on reducing the patient's symptoms? 1, raising their feet off the floor. 2, placing a lumbar roll behind the patient's desk. It should say back there. Should say back. That should say back, not desk. 3, having the patient sit on a cushion, or 4, modifying the desk to a standing desk. So I'll give you guys a moment to think about that. Again, question number 2 should say placing a lumbar roll behind the patient's back. All right, guys, so the answer is going to be modified desk to a standing desk. So let's go through these one by one. Again, I apologize for the typo there, but things happen. So let's kind of go over this. Number 1 says raising their feet off the floor. Now, what do we know about patients who have workplace, ergonomics? We always want the feet to stay flat on the floor. So if the feet are raised off the floor, then have you guys ever sat in done like a really heavy back workout or whatever, like deadlifting or something like that? And then you go to like a bar or something and you're sitting at a high top and you have no feet support and you're like, oh my gosh, my feet, they're dangling, they're hurting and stuff like that. And then you switch to like a low table where you can put your feet on the floor and you're like, oh, I feel so much better. It's because if your feet are unsupported, then you're using you're having to go into basically a posterior pelvic tilt, kind of in the sacral sitting kind of position. And it's very like painful and unsupportive and not good ergonomically for you. It puts the muscles in weird positions. So always having your feet flat on the floor is going to be great for you ergonomically. So number 2 says placing a lumbar roll behind the patient's back. So sorry for the typo again. So placing it behind their back. So what are we doing if we do that? So that's going to give them lumbar support, which is great. And so you would want lumbar support with a patient to avoid any other complications that they might end up having. So for example, could have complications with like, oh, I don't know, like a herniated disc or like, stenosis or something like that. You want lumbar support. It's going to help you avoid back pain. However, remember, as we talked about it, Piriformis syndrome is not due to the back. It's due to the pelvis positioning, not the back. So again, while putting the back in a better position will help the pelvis, there's a better answer for this, even though I do like having a lumbar roll. Having a lumbar roll is a great adjustment to ergonomics. So it's actually a good thing to be doing with this patient, but it's not our best answer. Having the patient sit on a cushion. So this is a great answer, having them sit on a cushion to decrease the pain on their, or to decrease the weight and pressure that's going to go through their piriformis muscle. Absolutely, this is a great thing to do. Would you do this? Absolutely, if the patient had to sit. However, the question is asking the greatest impact on reducing symptoms. And answer 4 says modify the desk to a standing desk. So this is going to be our answer that we want to choose, because this one is basically taking all of the pressure off the piriformis. Lumbar roll, adjust the pressure to be less. Cushion, adjusts it to be even less. Standing up, you got no pressure, which is the best option. So again, the greatest impact, which means the greatest reduction of symptoms, would happen if we moved it to a standing desk. Raising their feet off the floor, that's going to make it worse. So that's bad. So again, be like the last 3 answers of 2, 3, 4, those are all great answers to be doing with a patient to modify their work environment. But again, standing desk is going to make the greatest impact. All right, friends, I hope this was helpful for piriformis syndrome, and I'll see y'all soon. Bye.